Thanks very much, Grant. Thanks very much for being here. So what I really want to do is take you on a little bit of a journey that shows you, my slides aren't working, that takes you on a little bit of a journey as to what we've learnt in uveitis over the past few years and how it's sort of come into the 21st century. And there's hopefully 5 things that I'll be able to cover over the next 10 or 15 minutes. It's not advanced. Thank you. So the first thing I want to talk about is the Sun collaboration. And essentially, as you can see here on the slide, the Sun collaboration basically ended up with classification criteria for 25 common phenotypes of uveitis that we all looked after. It's basically a 17-year journey, this study. I went to the first meeting in 2004, and we had our last investigators meeting in 2019, and those 25 classification criteria were all published in the same issue of the American Journal of Ophthalmology in 2021. And essentially what we've now got is a language that allows us to talk around in a consensus manner to our colleagues around the world. We've got an agreed anatomical classification, descriptors for uveitis, severity grades. We've defined a meaningful change in vision. And what this means is that although these diseases have classification criteria that we use for clinical trials, they're really de facto diagnostic criteria for all of us to use in routine clinical practice. And this will lead to much better communication between each other. It will allow us to combine data from multiple clinical studies. I'm sure it's going to improve our understanding of the epidemiology and outcomes of different phenotypes of uveitis, and it will finally allow us to design multi-center disease-specific clinical trials. I'm just struggling to make this, okay. So I want to talk now about a couple of the really important clinical trials that have happened over the past 5 to 10 years. The first one is the MUST study, the multi-center uveitis steroid treatment trial, which ran over 7 years and essentially randomized patients to either systemic immunosuppressive therapy or Redicerts, which are intravitreal dexamethasone implants that last for 3 years. And the patients were then very carefully followed up for 7 years. And essentially the results of this study are that although both are very effective, systemic treatment gives you better visual outcomes over 7 years. The other important points are that 62% of the group of patients treated systemically needed some form of local or regional therapy at least once over that 7 years. Both arms of treatment controlled the macular edema in more than 90% of the patients, but in each arm, close to 50% had a relapse at some stage. Cataract surgery was quite safe in this group of patients and had good visual outcomes. And not surprisingly, 40% of the patients who had steroid implants developed glaucoma, whereas it was much lower at 8% in those on systemic therapy. So a really important landmark clinical study in uveitis. The next study was the FAST study, which compared the 2 common steroid-sparing drugs that we use in clinical practice. And again, an international multi-center randomized controlled clinical trial where patients were randomized to a maximum dose of either methotrexate or mycophenolate and then followed up for a year to see what happened. The bottom line is that there's no difference in efficacy between the 2 drugs, and there's really no significant difference in the side effect profile. And this is really important because methotrexate is a far, far cheaper drug than mycophenolate, and it's just as effective, and it's become really our first-line steroid-sparing drug. The next important study was the MERIT trial, which looked at different local treatments that we use intravitreally to treat cystoid macular edema in patients with uveitis. And so the drugs were an Ozurdex, an intravitreal dexamethasone steroid implant, an anti-VEGF, in this case ranibizumab or Lucentis, an intravitreal methotrexate, which many of us have used as salvage therapy in patients with non-responsive cystoid macular edema. And the outcome is basically that the steroids work and the other two agents don't. Methotrexate really had minimal effect and had a significant higher rate of 15-letter vision loss over the time course of the study due to persistent macular edema. Dexamethasone or Redicerts were by far the best drug in terms of efficacy, and not surprisingly there was a modest number of patients who developed mild rises in intraocular pressure. The next important study in this journey was the POINT study, where we looked to compare periocular with intravitreal corticosteroids to see which worked the best. So the arms of the study were periocular triamcinolone, intravitreal triamcinolone or Triesence, and again intravitreal dexamethasone implants or Ozurdex. And essentially the endpoint was to see what happened to the macular edema at 8 weeks' time, and the patients were followed for 6 months. So the important outcomes were that all drugs work at 8 weeks, but intravitreal therapy is clearly better in terms of controlling macular edema and improving vision than periocular steroids. In this trial, the orbital floor steroid patients were crossed over to intravitreal steroid therapy at 8 weeks. There was really no difference between the number of patients who developed raised intraocular pressure between periocular and intravitreal steroids. So if you want to control cystoid macular edema and you need local therapy, the most potent therapy is intravitreal therapy. It may not be the most appropriate choice in a phakic patient, but it's the most powerful therapy. So I've fairly quickly run through most of the important pivotal sort of uveitis clinical trials. There's two I haven't mentioned. One was the Sycamore study, which looked at adalimumab Humira therapy in children with JIA and showed that this was by far the superior treatment for those children. I haven't spoken about the visual studies, which were the sort of primary efficacy studies for Humira for adalimumab and showed that it was a safe and effective therapy. The other important study that I haven't had time to talk about are the SIGHT studies, which are huge retrospective case series of more than 20,000 patients with uveitis followed for up to 20 years. The most important outcome from this study, and the primary reason for doing it, was to see whether systemic immunosuppressive therapy caused malignancy and cancer, which it does in so many other diseases where we use immunosuppression. And the important thing is there is no increased mortality from lethal malignancies in patients who use systemic immunosuppressive therapy for uveitis. You do get non-lethal malignancies, you get cervical cancer and non-melanopic skin cancers, but these are obviously readily treatable. For us as ophthalmologists, probably the most important message is that in the long term, for patients with chronic uveitis, 50% of our patients are going to develop glaucoma. And that's when I was a fellow, my sort of mentor always said that the final battle in our patients with uveitis was dealing with the glaucoma. And this clinical trial or this clinical study confirms that. These clinical trials that have been done, and now that we've got the SUN study and the SUN criteria to work with, there's now a whole raft of really important clinical studies that are underway that are going to further define how we look after our patients and which combinations of medications are the best. So the next thing I want to briefly touch on are registries and collection of data. And there's an increasing number of uveitis registries and data banks out there. And the one that I'm involved in is one called this group of registries called the Save Sight Registries from the university where I work. And we've recently launched a uveitis database, outcomes registry rather, called Fight Uveitis Blindness. And just to show you the power of these outcomes registries, we only started collecting data 4 months ago, and we concentrated for a particular reason on getting as much data as we could on patients treated with adalimumab or Humira. And across Australia, we got 261 eyes of 141 patients who'd been treated with adalimumab. And as you can see, it's the usual sort of collection of diseases that cause vision-threatening severe uveitis, mostly posterior segment disease. And these diseases, or these phenotypes of uveitis rather, have always been very difficult to treat, particularly, for example, a disease like birdshot choroidopathy, where 20 years ago the vast majority of patients with this disease went blind, as did the majority of patients with Behçet's disease. So when you treat these patients with adalimumab, this is just a 2 or 3 slide summary of a large amount of data. The important take-home message is that there's this really powerful, prolonged, sustained steroid-sparing effect. And as you can see in these 261 eyes, 2/3 of them, 66%, were able to stop all systemic steroid therapy, and 87% of them were down to a safe dose, either 0 or less than 7.5 milligrams per day. And that's something we've never been able to achieve with other medications. Very importantly, these patients, this treatment stabilized the vision in our patients. It controlled the uveitis, it got rid of the macular edema, and essentially in the vast majority of our patients, 87% of them, visual acuity, it was either stabilized at its current level or improved, and only a relatively small number of patients lost vision, and this was usually fairly mild visual loss. So the message here is the sooner you can get your patient on to a drug like Humira that works, the better the visual outcome is going to be. So this is just one example of the powerful data sets that an outcomes registry can generate. Obviously this one's in uveitis, but our group of registries has got registries for diabetes, macular degeneration, retinal vascular disease, glaucoma, a whole range of different registries. But the uveitis one, I think, shows you that real-world data is really important in supporting the sort of somewhat artificial randomized clinical trials that we do. It gives us good, useful, ongoing data as to what's going to happen to our patients in the future. And in this particular case, it showed a powerful steroid-sparing effect. It allows us to reduce treatment and gives us really good visual outcomes. And that really leads on to the last 2 things I very briefly want to finish with. One is that to manage our patients with severe uveitis and vision-threatening uveitis, we need to do this in a multidisciplinary team, in a multidisciplinary clinic. In my uveitis unit, we have a rheumatologist who comes to our clinic every week. We have our own sort of personal on-call infectious diseases physician that we can tap into whenever we need to. And by seeing our patients in the one place together or sequentially, we can get much better visual outcomes, clear communication, make sure that the patient understands what needs to happen, and ensure that we look after the patient holistically and get the best visual outcomes. So that then allows us to use, shall we say, aggressive immunosuppressive therapy to control the uveitis. And for the majority of our patients now, that's systemic therapy, which we use obviously in people with bilateral disease and people with severe unilateral disease when there's an inflammatory mediated threat to vision. You obviously need to exclude infection, but it's important to note that some infective forms of severe uveitis, such as herpetic retinitis, syphilitic uveitis, and toxoplasmosis, need immunosuppressive therapy as well. And the common inflammatory mediated threats to vision that we tend to treat, cystoid macular edema, occlusive retinal vasculitis, and multifocal choroiditis. And in the light of the clinical trials and the recent data on Humira, what we do now in my unit in Sydney is that we'll start the patient on systemic steroids, add in methotrexate, usually, occasionally mycophenolate, and then try and taper the steroids. The patient will either go into remission, or if they relapse, we will now go straight to escalating the treatment to a biologic such as adalimumab. If there's further relapses, the MUST study tells us that's not uncommon, and we can usually control them with local therapy. There's going to be a study we've been investigators in called the ADVISE trial is working out whether this paradigm is actually the correct one and a safe paradigm for our patients, and we should have the answer in about 12 months from now. We still need to use regional steroids, as I said. Often we use them to supplement treatment in patients who are on systemic immunotherapy, but sometimes patients with, say, steroid psychosis, we use local therapy in both eyes. And it's really very useful sort of periocular and intravitreal steroids. But you have to be sure that there's no infective, that it's not an infective uveitis. So to finish up, the Sun classification criteria have moved us into the 21st century. We've now got a growing number of clinical trials that have provided important evidence to guide our therapy. We now know that systemic immunosuppressive therapy is safe and effective for our patients. We've got registries that will allow us to modify our therapy and benchmark our outcomes, and multidisciplinary clinics will help to ensure that we give our patients the best chance of a good visual outcome with minimal side effects. So don't be afraid to recommend and use systemic immunosuppressive therapy. Thanks.